Okay, I think that's everything. So
minimize so we can see the whole screen that minimize
the view,
the view.
yeah. Better, yeah, okay. All right, so like I mentioned, I am going to give a brief introduction to random forest for recurrent event analysis tonight. We will start with. There we go. An introduction to recurrent events. We'll talk about some of the ideas of how statisticians have analyzed recurrent events. We'll talk about something specific called a censored longitudinal data structure. And with the censored longitudinal data structure, how we can create something called a pseudo observation. This particular statistical device is really useful for when you have survival analysis type data and censoring. Then we'll briefly go over some regression models, including a random forest for historical and recurrent events, as well as thinking about what kind of historical covariates we can include in our random forest and regression models. Go into some results from a simulation study, and then if we have time, we'll go over a quick data application. Okay, so recurrent events are really common in healthcare settings. As statisticians and biostatisticians, we often see people coming into hospitals or going into clinicians' offices getting the same type of event over and over. The initial idea for this project came from a hematologist at Michigan Medicine who talked about giving patients chemotherapy. And if you go in to get chemotherapy for your cancer treatment, sometimes you have something called venous thromboembolism, where you throw these blood clots. It'd be really nice to be able to predict what kind of patients are going to have their blood clots, when they're going to have their blood clots, maybe get some idea of what factors are related to these types of blood clots. But as you can see or think about, these kinds of outcomes are really common. So people have rheumatoid arthritis, or maybe they have alcohol use disorder and they go through periods of relapse and going back to their alcohol use disorder. Breathing emergencies for pulmonary patients. You oftentimes see people coming back into emergency rooms and then getting some steroids and then going off and living their lives. So single time to event models that we've developed for things like cancer or car crash or fatality type data don't work for multiple such events. We're going to need a completely different or a completely new way of analyzing this data. So this is a common just toy data example that we're going to see throughout the presentation. And we've got 3 different patients who have different censoring times indicated by the CI. So this is when we stop following. Either they move away, or they drop out, or they decide that they don't want to be followed anymore. And sometimes we say, oh, the end of our study was 240 days. Sometimes the censoring can be administrative. And then X1, or XI1, XI2, XI3, and XI4 indicate the possibility of having these repeated events that we're interested in analyzing. So we can also think about this data graphically, and thinking about it in times. We've got each of these events plotted for our hypothetical patients, with X's denoting when an event happens. And you can already see that patient 3, while they stay in our study for longer, has more events than patient 2, who gets censored shortly after 120 days, and patient 1, who gets censored around 215 days. So formally, we've got up to n subjects having at least one event recorded at times TI1 less than TI2, on and on and on. These times are potentially censored by a censoring variable CI. We are going to assume that the censoring is independent of TI, but we can only observe these X star variables, the minimum of our times and our censoring variables. These are potentially censored, so you could say patient J has NJ events, but you don't actually observe all of their events potentially. And one of the ways that statisticians have sought to analyze these recurrent events is analyzing gap times and thinking about, okay, if we have patient 3, we can say start of follow-up is here, then their gap time is this length of time in between their events. There are some problems with this type of analysis though. As soon as you have correlation within a patient, which tend to assume if you have individuals who are measured over time, then there's a problem with censoring and informative censoring for our gap time analysis. So a lot of gap time analysis assumes that events within a patient are actually independent, which is a large weakness of these types of models. So we aren't gonna model in gap times. What we're gonna do is something called a censored longitudinal data framework. So first, we're gonna pre-specify multiple follow-up windows of time P in this fancy script T, and think about a tau length window of clinical interest. This isn't super intuitive. You can think about, well, why would we do this? But you can also consider the fact that if we're interested in, say, year-long survival, as soon as you start enrolling patients, everybody has a bunch of year-long survivals. They just don't all start at baseline. And now we're going to say, okay, at 0, 60, 120, we're going to consider your tau length survival from those points in time. So we don't really care to a certain extent when your last event was. From this point in time, we're really interested in knowing how long until your next event. So we're going to consider recurrent event-free time greater than or less than tau. Ideally, we would be talking about these T sets, these times of follow-up windows, and this tau in clinician or in consultation with the clinician. This kind of data set is pretty common if you think about clinical trials, where you're going to give someone an agent and then they're going to come back in and we're going to follow them over time and see when their recurrent events are. So formally, we're going to take each T, each time point in our set of times for each individual, and we're going to identify the very first recurrent event that we see after time T with this A to I variable. So that's going to get our first recurrent event after a specific time. We're going to calculate residual survival time and corresponding censoring survival time. So we can think about that graphically, but for patient 1, at time 0, they have 80 days left. At time 60, they have 20 days left until their next event. We observe this event for patient 1, so their censoring indicator is still a 1 in both of these cases. For patient 2, they don't have any events. So when they're censored at 125 days, that's the only event that they have left. But they also have no events across our study and are censored. Yes.
When you were going on patient 1, you talked about the first 2 rows. And the third row where you have T of 120 and X is 83, what does that mean in that?
Right. So at time 120, the next event that patient I experiences is XI2. So A to I, or A to 1 of 120 is 80, is our second event.
Okay,
So it gets the
got it.
second event.
I see.
And then, yeah, we've got 83 days from time 120 till your next event.
Oh, okay, thank you.
And I've got a graphic on the next page that'll kind of help to get the intuition for this. And so we construct our longitudinal data frame by kind of stacking these triples of time point, residual event, recurrent event-free survival time, and our censoring indicator. So this gets back to your question of how much time do we have at each one of these? So for 120 for patient 1, we kind of go all the way to that second event. And we're covering more than, like we're going beyond 180 for this patient. So that is something we will need to be careful of, the fact that we're recording the same event multiple times within our data frame. We can also notice that patient 3, we don't actually capture this third event in patient 3. But we're capturing a lot of our events. And
Why don't you capture that event?
Right, so we're gonna go back to eta 3 of 60. So the first event that happens after time 60 for patient 3 is 62. So there are 2 days left until their next event, but we don't care about how many events you experience after your first recurrent event in that window. We just want to know what is the time until your first recurrent event, given that you've survived up until time T. So we miss 75 because there's no follow-up window that we've pre-specified that is between 60 and 60.
It seems like you're throwing information away. That's why I'm wondering,
Yeah, there's this interesting balance that we have to do when we're pre-specifying our follow-up windows and our taus. We have to kind of balance this whole idea of how much granularity do we want to think about our data frame? Because if a patient has an event within a week, but this kind of frequent event is not very common in our data set, do we really want to be taking these measurements and creating this data all that time? So there's a computational trade-off that we're making.
Thanks.
So this also gets to your question about these user-specified parameters. We're picking the spacing, so I've kind of denoted A, spacing between our windows, and tau, our window of interest. A should be constant for the most power, and it can be as small as possible. There's that trade-off with how many of these repeated measures are we thinking about taking on a person. There was a paper by Shia and Murray in 2019 that kind of played with what are the best choices for our different recurrent events? What is the best choice of tau? What is the best choice of t? Okay, so that's our censored longitudinal data framework. We have a way of thinking about recurrent events that doesn't rely on gap times. But now we want to be able to associate covariates with this censored longitudinal outcome. And so we want to perform something called regression. But if we remember, the problem with gap time analysis was that we had censoring. So how are we going to deal with this censoring problem? If our data were complete, we would be able to take an empirical mean of our outcome and set up our regression, probably specifying some type of a link function of our expectation and our covariates. So pseudo observation is how we're going to move past this.
Before you even go to a regression problem, is there an estimation problem, like a survival curve that's possible out of that? And like the Kaplan-Meier before going to, did you do that and I miss it, or you're just not?
We're not doing specifically that. We're going to use some of that.
Okay.
We're trying to build up to this outcome of how are we going to think about what is the correct outcome in this case.
So I think for things like random forest, the main goal is prediction of, what's the probability they'll have an event in a window. And so lots of that over time might be done. Theoretically, you could get at it if you ran a bunch of these and find probabilities over time, but the survival curve isn't probably going to be this isn't the tool for that.
Okay.
But figuring out probabilities of being event free in different windows over time.
And how it's associated with covariates
Yeah.
is the goal. Gotcha.
Yeah.
Thanks.
So it's going to look more like longitudinal data plots, really.
Okay. So our outcome is going to be something called a pseudo observation, which is kind of a weird looking object. It's not necessarily intuitive when you look at it, why it works. But if we have an unbiased estimator for a parameter of interest, so we can say theta is our quantity of interest. We have an unbiased estimator for that data. We can also calculate its leave one out estimator. And then we're going to define a pseudo observation for our quantity of interest to be this guy. We're going to talk about why that works and get some intuition into what's going on. But the main takeaway from pseudo observations are that they're unbiased in the presence of censoring in large sample regression. So if we're doing regression on covariates and we have pseudo observations, we don't necessarily have to worry about censoring anymore. It's a great tool and it's pretty common in survival analysis literature after, think about like the early 2000s is when they were introduced. The proof is involved. It relies on some measure theory concepts and the law of large numbers. But like was mentioned earlier, we can think about an intuition for probability of survival greater than tau. So this is the definition of a pseudo observation. And we know that our Kaplan-Meier estimate is roughly unbiased for survival probability. And so if we think of people at risk at time t, right, because our population might change over time, the number of people might get smaller because of censoring. So say n of t is the number of people at risk, n of t minus 1. So we're going to fill in what this theta I of t is. And so if we don't have censoring, this is just a rough intuition of why this works. Our Kaplan-Meier estimate is just the proportion of people who have events less greater than time t, you know, people who survive greater than tau, divided by the number of people at risk. But the numerator and denominator are gonna cancel out. So what we end up with are N of t indicators on the left and N of t minus 1 indicators on the right, leaving behind our ith indicator. And so if we take the expectation on covariates, we really just get an expectation of an indicator, which was the probability that ti is greater than or equal to tau. All right, so our pseudo observations for Kaplan-Meier probabilities is what we're interested in. We want to know, for a patient, did you survive more than tau length of time?
Or event.
Or recurrent event free?
No,
Yes, recurrent event free.
No.
For more than tau. Okay, so putting it all together, we've got our data recorded as just a bunch of different observations. We're going to select an appropriate tau length window and an appropriate spacing of our follow-up windows for creation of our censored longitudinal data framework. We're going to transform these events that are kind of given to us in this raw wide format into our censored longitudinal data framework. And then for every single person and for every single time point, we're going to calculate a pseudo observation for that person. This will let us perform unbiased regression of our pseudo observations on some covariates that we're going to record. This also kind of gets back to that idea of, you know, why did we have that one patient all the way back here who were missing this? Why didn't we just have a bunch of these different follow-up windows? We're going to calculate pseudo observations. We have to calculate the leave one out estimator for every single person at every single time point. So it can get really, really computationally intensive really, really quickly.
So it could be done, it would just take a long time for the computer to spit out
So-
the data.
You need to get the estimator and the leave one out estimator for this. And that's a formulaic computation. Is that what you're saying? It's not, it's just a turn the crank or it's,
Yeah,
okay.
yeah.
Yeah, so each follow-up window start time, like 0, 60, were those the, yeah. You have the Kaplan-Meier for that follow-up window and the Kaplan-Meier leaving out person I for that follow-up window to get the pseudo observations. And then you do that for every time you slide the follow-up window of interest over, you have to recompute the Kaplan-Meier overall and leaving out each person separately.
So it's always a Kaplan-Meier estimator here. It
Here
doesn't,
it is.
it could be another kind of estimator.
Totally, yeah, it could totally.
That's what I was wondering.
Okay, as long as you have a nice unbiased estimator for your quantity of interest, you can form all kinds of pseudo observations. So you can do, there's some literature of tau restricted mean survival time. So we're gonna look at up to tau. Do you have an event for tau? Do you have an event? That's particularly nice in the recurrent event context because oftentimes tau restricted mean survival time is like, if the world were to end in tau length of time, would you survive or not? But now you can say, well, if the world were to end in tau length of time, don't worry, we'll see you in a week. That kind of like updated estimate for every single person. So pseudo observations are super flexible. As long as you have this unbiased estimator, it works out real nicely. Okay. So we want to be able to do this unbiased regression of our pseudo observations on our covariates. What we have are longitudinal measures on a patient. So we had the left 4 columns. We didn't have these pseudo observations until the past few slides. And now we're going to think about recording some covariates at every time point. This is really nice because now if you think about you go into the doctor every 60 days because you're on a clinical trial or you're really sick, we can record your blood pressure at different time points. We can record your weight. We can record all kinds of things about our patients, and we can see how these covariates vary over time and how they're related to our recurrent event-free survival probabilities. We're gonna have multiple observations per person, and we also are gonna have that issue of we record the same event multiple times in our data set. One of the other things we thought about when we were doing this non-parametric and parametric regression was if you have recurrent events, you'd like to be able to include something about a patient's history. You as a patient tend to be very sick and you have recurrent events very often. Or maybe your patient doesn't have recurrent events very often. And we want to be able to understand how this patient history is affected, or like affects our survival probabilities. One of the problems though is that our patient history might not be super full. Somebody comes into a clinician's office and they say, oh, well, how often do you have your breathing emergencies? They might say, I don't know, doc, like maybe once a year, maybe 5 times a year. So it's this kind of idea of we might have a patient's full history, we might have no event history on them. We might be in the case where we're analyzing some data and we just didn't record event history for a patient. Or we can also think about, well, we don't have your event history at enrollment for a patient or at time 0. But as time goes on, we're recording your event history. So we've got this partial information on patients that should be increasing in its information and its quality over time. So we want to be able to include this covariate as well and kind of experiment and see what are the best situations for these and how do these covariates of patient history change our ability to predict patients' outcomes. So just so that we're kind of set up for the next few slides, we're going to think about 3 different scenarios. No event history, HF of T, so full event history, or HP of T, which is partial event history. We're also going to introduce 2 different regression models, something called a modified XMT model, and then a historical random forest. So a modified XMT model takes the longitudinal data in our censored longitudinal data framework with our Kaplan-Meier pseudo-observations, and then we just fit a parametric model via generalized estimating equations. There was a paper in 2020 that showed that if we're doing minimum or tau-restricted mean survival time and regression on covariates, we can actually have good unbiased estimates of those same covariates for recurrent events. We're going to modify their model slightly for our Kaplan-Meier pseudo-observations, specifically for the case of prediction. So we're looking at the expected value of the probability of xi of t being greater than or equal to tau, equal to some covariates that are possibly time varying. So this is our modified XMT model. And then the other model we're going to talk about is the historical random forest. So first we're going to talk about a random forest, and then we're going to talk about a special random forest. A random tree, just briefly, is a series of indicator functions that are selected to minimize some type of objective function. So we pool all of our data and we're going to make splits that are going to minimize an objective function. So if I gave you this data where we've recorded some X and Y covariates, and then we also have the responsive color, you're like, oh, okay, well, clearly anything that has an X covariate greater than or equal to 2, we're going to call that green. And then we're going to make another split of our data, and we're going to look at the Y-axis. And anything that's above 2 in the Y direction, but also less than 2 in the X direction, we're going to label red. And then everything else gets labeled blue. So it's this way of kind of formalizing the idea of we're going to try to sort our data into categories that are the most homogeneous among what are called leaves of our tree. Random trees are great. Unfortunately, they can overfit to your data. So we want something that's a little bit more generalizable. So if 1 is good, we're going to actually do 500 and we're going to call it a random forest. So for each one of our potential replicates of up to 500, so from 1 up to capital R, we're going to sample with replacement from our observations. These are going to go into something called our bootstrap for replicate R. Observations in BR are called bagged. Observations outside of BR are called out of bag. And then for each one of our replicates, we're going to subsample covariates out of all of the possible covariates that we have. And then we make our random tree. A couple of things to notice. We're going to subsample covariates that if there's just like one really important covariate, it's not always getting selected into our random tree. The subsampling of covariates helps to kind of make our trees a little bit more generalizable, a little bit more have a little bit more variety, and we're gonna traverse the covariate space a little bit better. Fitted values for a random tree. So if we're trying to do some type of regression, we want to get these estimates. So we're going to have fitted values for our random forest regression using the out of bag sample. We're going to average in the terminal leaves. So if you weren't put into BR, then we're going to pretend that you're a new observation. You're just going to follow the tree. For individual I's prediction, you are going to average all of the possible out of bag predictions for individual I to get individual I's like resulting prediction from their random forest. So that's just random forest algorithm in general. There are a lot of different versions of random forest. There's like random forest for survival data. There's random forest for categorical data, random forest for continuous data. And we're going to talk about historical random forest.
Can you quickly go over again the out of bag versus bagged? I'm not clear about what the difference was.
Yeah, so if you are bootstrapped in a certain replicate, so we're gonna say like replicate 10, if we include individual or like observation I in B10 for creating a tree, you have been bagged.
Okay, so it means it's in that particular sample. Okay.
That observation is used in the
Got it.
construction of
Thank you.
that random tree. Yeah.
Can you think of them like test and training?
Yeah,
That's kind of.
yeah, and oftentimes if you look at random forest documentation in R and you look at like prediction out of bag error or prediction error, like some type of a similar like syntax in R, those predictions come from your out of bag sample. So this is really nice for just single observations because we know that I was not used in, or like a observation that was out of bag was not used in the construction of that tree, so it should be independent of whatever that response is. So you aren't saying, oh, like, what is my fitted value? Oh, I have a subject who is just like this. We're gonna follow what that subject did in our tree. So it's not like exactly like perfectly fitting. It's one way to kind of avoid this problem of overfitting that we get with tree regression. So we have potentially correlated longitudinal data. We have a bunch of measures on people over time. And so this is a problem because if subject I has their first recurrent event at 60 days, we bootstrap xi of 0 into a tree, this might tell us that xi of 60 should have a value of 5 without doing any type of regression or using anything on the covariates. So we have to be careful about what data gets bagged and what data doesn't get bagged. We also want to be careful that if we have one patient who has a lot of signal in their data, but they only show up in one of our follow-up windows, that they aren't going to get overpowered by a patient who shows up in all of our follow-up windows, but whose information may not be as quality as that one patient with one follow-up window. So we need to be careful about how we're going to bag our observations for construction of our random forest. There was a lot of work around this, like the 2010s, like 2010 to, I guess, present day. And Adler proposed this two-stage bootstrapping scheme. So instead of kind of just putting your data in and then bootstrapping rows, you're going to bootstrap IDs from 1 to n, and then either sample once from your individuals, and then every time you see, like if you pick observation 20, we're going to pick one of person 20's observations, and every time we see a 20, that's going to be our bagged sample, or we're just going to bootstrap all of person 20's observations into our random trees. The second method, where we're actually putting all of our people into our random trees, is implemented in a package in R. So that's what we're going to use. It's called historical random forest. So when we apply this random forest to survival data and pseudo observations, I'm just going to call it rfre.po. It's really nice because our out of bag samples for our trees are still independent of our bagged samples in our trees. And having all of the observations within a person in a bagged sample is going to help kind of get this correlation. You know, if your covariates at baseline looked like this, but then 60 days pass, well, now maybe you have a much lower chance of being recurrent event-free greater than tau. So we want to test this. We want to see how does our random forest, or our proposed random forest, work in simulation. Basic idea behind the simulation study was generating correlated exponential gap times that follow a very specific hazard. So we know the hazard of our exponential gap times. And we're going to look at 3 different models. We're going to fit a modified XMT model, so that model that we fit with GEE that perfectly reflects our generating hazard. So that was your God, you know exactly how your covariates relate to your outcome. And that is the best we're going to be able to do in this situation. We're going to fit a main effects modified XMT model, model B, and that's, you're just doing the best that you can with this data. This is how you think the data works. This might be kind of what you take a first stab at if you're given the data to model as a statistical analyst. Then we're also going to fit our random forest pseudo observation. So more specifically, our generating hazard is going to look like this. It's pretty ugly. I don't think if someone gave me this data set and was like, I think you should put a sign term in this, I would be like, I think you should leave. So it's meant to be messy, right? It's meant to be something that you wouldn't think, this is what I should do. Z1 through 4 are going to be continuous, Z5 through Z7 are categorical. Other things we talk about in our simulation study, we're going to set tau to be 1/6 of a year, roughly 2 months. And then check-ins happen every single month for 2 years.
How many events are you gonna observe? Maybe that's the next slide. Are you, how big is your sample? Yeah.
The sample was, that's a good question. I think it was, I don't remember. I think this,
Is it on a slide?
no, I forgot to put it on the slide. I don't agree that we didn't even put that in the paper.
Well,
We'll figure.
I'm sure we
I think we
did.
Are we talking 100,000 or 1,000,000 or?
No, we're talking somewhere in the order of 100,
Oh,
200
okay.
people.
100 or 200 people, each with several events.
Several events. We did have this like range restriction because you can think about if you have these continuous variables, then you could have like really, really tiny lambdas all of a sudden if you have like largely negative ZI3, for example, because then all of a sudden your lambda gets really small. If your lambda gets too big, same thing could happen. So we did this kind of trick where we said, okay, we're gonna set, I think it was a fifth, like 2, if I'm gonna guess. So people are expected to have a certain number of events. It just kind of keeps things a little bit realistic.
So just to brief, you eliminated people who had hazards that were so horrible. They were having recurrent events like every day.
Yeah,
Yeah.
yeah. I think
So it follows that model unless it puts you at a hazard that makes it
absolutely
practical.
makes sense.
To put in a data set.
Yeah.
Yeah, or you can also think about it as like, we're gonna look at a specific type of population and you aren't gonna expect people who have COPD to have a breathing emergency every 5 hours. Or every 5 seconds. So it's this kind of like way of making our simulation study a little more realistic. And then for each one of these models that we're gonna look at, we're gonna consider quality of historical information. So here's where we thought about HF of T, HP of T, and then no historical information. And this is just a formalization of those variables that we're gonna put into our model. So HF of T, we have this augmented time. We can actually look back at time and consider, oh, did you have an event before baseline? And then we're gonna include that in this kind of averaging of your behavior. HP of T, we don't know what your history was at time 0. So we ended up doing something kind of just drawing from an exponential distribution. This exponential distribution was related to the average across all of our patients. So it's kind of like, you can think about it almost as like a non-informative like prior, it's not really Bayesian, but it's this idea of we don't know what your event history was, but on average, people tend to behave like this.
So it's frequentist trying not to be Bayesian, but kind of being Bayesian.
Yeah,
Zero days.
yeah.
So does that mean exponential 7.5 e to the 7.5? Is that what that means there? Or
It's an exponential distribution.
just, okay, got
I think
it.
that's the best.
Distribution.
And that's the hazard, not the rate.
Okay. So again, this is our hazard. Model A was that XMT model with our Kaplan-Meier pseudo observations with perfectly specified to reflect it.
Hmm.
Model B, our main effects model, and the model C is the random forest where we don't have to do any of this special deciding exactly what covariates are gonna go into it.
So it's God and a statistician and a data analyst, these are models A, B, and C.
And a bot.
Yeah.
Okay, we're gonna compare our models using a C statistic. So the C statistic measures the proportion of correctly ordered observations. Briefly, you take a pairing Ti, Tj, if the predictions have the same ordering, we're gonna say they're concordant. So if Ti is less than Tj, but Ti hat is greater than Tj hat, the pair is gonna be discordant. C is the number of concordant pairs divided by the number of concordant plus discordant pairs. If you have censoring, it's a little bit more complicated, but it's pretty much the same idea, it's a proportion. A C statistic ranges from 0.5 to 0.1. A perfect model, again, if you're God, it's gonna be 1. If you're flipping a coin, it's gonna be 0.5.
My in-laws have a C statistic that's lower than 0.5. It can technically be lower if you really, really just disagree.
Yeah.
So that's not strict, that's not an algebraic relationship.
Yeah.
With positively correlated data, that's what happens.
Okay.
Hmm.
But you can get from less to 0.5 to more than 0.5 with a minus sign. So-
Yeah, just like change it.
If you just want to change your categorization.
That's right, you can do better prediction by.
Yeah.
Technology.
Okay, so remember, model A, model B, model C, and these are our C statistics. Hopefully everybody's doing well. It's a really messy plot in that we have a lot going on. So across the top is levels of correlation within a patient. So we were able to induce some correlation in our simulation and think about, okay, if your recurrent events are totally independent of your previous recurrent events, that's when our level of induced correlation is 0, all the way up to 0.9, which is very highly correlated. And then vertically, we thought about levels of censoring. We almost never have perfect follow-up in real data, which is why we needed our pseudo observations in the first place. So we applied different exponential distributions to kind of think about, okay, now this person is going to be gone after this point in time. And then within each box, the level of historical information increases from none to partial to full. And the results are pretty comforting in that when we have highly correlated data, including any type of patient history covariate is going to improve all models vastly. In the completely independent case, we can see that our random forest seems to be able to deal better with our partial historical information than an XMT model that's just main effects. So it's able to kind of take in this idea that our historical information is not great at baseline, but it increases over time. As we go down, the level of information that we have, just because censoring has been induced, is going to decrease. But in all of these cases, the random forest algorithm is performing at the same level or above than our XMT model that is just main effects. So this is your statistician, you're going to model this parametrically. That's model B. Our random forest is able to outcompete and outperform these models in all cases.
I don't see dramatic differences in the plots when I look vertically for censoring. I mean, I see some shape changes in column 2, in column 3. But I was surprised that with the level of censoring, these things are so robust. They don't change that much.
Yeah. I think that might have to do, I guess it's probably with sample size, right? We have those unbiased pseudo observations in the presence of censoring. And so because we have these unbiased parameter estimates, we can still get at mean behavior. Even when we do have the censoring.
I think it's a legit observation.
Yeah.
I think it's a legit observation. I don't know.
What's a legit what do you mean?
Yours.
You said something legitimate, so I try to imitate my teens, Gen Z.
Oh,
stuff whenever
gotcha.
possible,
Okay,
and
yeah.
sometimes it.
Do I have any riz?
Yeah. Don't make me pull out all my.
All right.
It's not good, it's not pretty. So I think you're right, I think that there is very little difference as you go from high sensory.
I don't know if you could quantify none to high in terms of how does that affect your number of events that you've observed?
Yeah,
I always think of survival analysis as sample size, how many events did you see?
okay.
And if you're going from, 10,000 to 9,000 by censoring, yeah, not much happens, but if you're all of a sudden got only 10% of what you had before,
Yeah,
it's a
Yeah.
bigger change.
So when you were designing this, remind me, you said that you changed the hazards to control the sensory.
yes,
So when you compare first, second, third row, are those different hazards that you got going on there?
yes, those are different hazards.
Okay, so there's something, it's not quite like you're looking at the same data sets. So that's probably gonna confuse people. If you change the size of the data sets from row to row,
Oh,
then they're not exactly
yeah,
comparable. So most of us would look for like bigger spread
Mhm.
okay,
and everything, but you change the hazards, so probably you probably are somehow manufacturing almost the same statistical information in each row by manipulating the hazards to get.
I didn't change the hazards of individuals, so I didn't change recurrent event hazards, I changed like the hazard for the censoring distribution.
Sensory.
Right, because the censoring was applied independently. I think,
So the weakest model is the purple, because that's just main effects. And it really does look almost the same. I wonder why that is. I would have expected more spread as you had more sensory too. We probably figured out why this was a long time ago. And brought it up, but I don't remember it.
I don't either.
Biggest changes I see are the changes in the shapes of the blobs in the second column on the
Yes,
left side. I don't know what that means, but it's just, other than, I mean, I'm just using the
yeah.
interocular traumatic test.
I think one of the things is that when you're including, maybe included the historical information, is just adding it as like a beta 8, this extra covariate in the end of our models. And sometimes that resulted in really unstable models. And so maybe that has to do with the fact that we had these huge variances with our parameter estimates, and so across time, we get these very variable estimates, but
Interesting.
yeah.
You didn't really talk much about when you go from left to right.
So,
Inducing correlation.
do you mean left, right within a box, or do you mean?
Within a row.
Within a row, okay, yep, so that's more correlated events, so the amount of information that you have that is good for, mining the probability of survival greater than tau is going to increase, and particularly with the inclusion of historical information, we're able to get at this idea of your historical covariate should now be very, very important. Because if your previous history is going to be highly correlated with your future history or your future events, then that should be really helpful for prediction. And to some extent, as soon as we include a history variable in this highly correlated case, I'm just no censoring for now, we see that there's just like this massive jump in model performance. Any other questions about this picture? About 10 minutes left. So I'm gonna try to go through our data application. So this works with chronic obstructive pulmonary disorder patients. There was a clinical trial in 2011, working with azithromycin, trying to prevent people from having to go back to the emergency room to get steroids because they're having breathing emergencies. COPD is usually associated with a smoking behavior or smoking history, but we can see that any type of bad chemical that you're breathing in is likely to also increase your risk for COPD. If you have an exacerbation, it tends to make your disease worse, and you tend to get worse and worse over time. So this ability to predict the probability of remaining exacerbation free over a 180-day follow-up period is actually really will be meaningful, and kind of thinking about the ways that we can give patients an idea of how their disease is progressing and how they're doing over time. We had 1,058 patients in this, and we also did, I think, 30-day windows. So here's just a pretty picture of all of the variables that we had access to at baseline. These are the continuous ones. There were even more categorical ones, but there are patterns of high correlation, right? So all of these ones of like mental health Z-score, aggregate mental health Z-score, emotional Z-score, like social Z-score. So all of these like kind of mental social well-being variables are correlated with each other, which makes sense. If you're not functioning very well physically, we might expect you to not have a very good, like be very healthy. And so as we measured all of these different variables, there is this pattern of correlation. And I think there were almost as many possible variables as there were patients, because there's also like a sleep study that was conducted at the same time. So we had clinical measures, we had sleep measures, we had mental health measures. So if you're looking at this data, you're kind of considering like, how do I even begin to model this? We were also able to go into this idea of historical covariates. So we had a categorical time since exacerbation and an exacerbation rate on study. So thinking about how many exacerbations have you had at window 60 versus how many exacerbations have you had at window 180. And you're kind of able to derive this as a modeler. So our window of interest was 180 days. We had check-ins at 0, 30, 60, 90, blah, blah, blah. And then this data was also looked at in a paper by Shia in 2020, and they were looking at specifically like, how do we think about treatment effect and controlling for all of these other variables in getting an idea of like difference between groups. We also looked at, if you're a modeler, you might do like a walled forward selection process to kind of winnow out your data and think about how am I going to best model this. So we included variables in our model based on walled scores. The largest walled statistic was included in our model until that introduced model instability. So because we had this highly correlated data, say aggregate mental health Z-score has a huge Z statistic. So we put it in our model. And then the next one that is indicated to put into our model is general health Z-score. But now we have like huge variance estimates because our variables are correlated with each other. So it's like a wall forward selection as long as you don't include variable, increase model instability. We also did an RFRE.PM. And as mentioned, we are in the partial information setting. We use the C statistic to analyze the effectiveness of our models. And then with random forest, you don't get your traditional point estimate and variance estimates. So you don't get this idea of like, oh, can I do a hypothesis test to see if these two groups are different in some way? What you can do is a variable importance. So there are a bunch of different variable importance metrics. Specifically, what we talked about was a variable importance for prediction error. So for every single variable in your random forest, you're going to select your variable W. In the out-of-bag samples, the sample that is completely independent of the sample you use to train your tree, you're going to permute your variable. This is gonna break your variable's association with your outcome. You're gonna get a bunch of different permutation distributions of your variable. So this permuted variable is denoted WS. For each of your permutations, you're gonna calculate the difference in prediction error between your original W, so your whole, completely related to your outcome W, and your mixed up W that should have no relationship to your outcome. You're gonna calculate the sample standard error of these prediction errors. And then exploit the fact that asymptotically, these prediction errors have a standard normal distribution. So you can get a type of walled statistic, which will kind of let us think about the way our random forest is working in comparison to our traditional XMT models that are a little bit more comfortable to think about if you think about a GEE. We can get some p-values and get some idea of which covariates are really important in our random forest. So this is the results, ooh, that did not render well, from our modified XMT. So these were the covariates that Xie et al. In 2020 had identified as important in thinking about COPD. And then our modified XMT walled forward selection loop came up with a bunch of different variables that were important. So we've got our partial history information up here. It's exacerbation in time 0 to 30 days, bronchiectasis diagnosis at time T versus no diagnosis, male, gender, treatment group, medication usage, it's the type of medication that you're on, and then some clinical measures. We've got another patient history variable that popped up as important, and then steroid use. Okay. Next model from our random forest.
So you came from you got the same ones that Gia did, and then you added some other variables that.
So we
show
got
up.
We got some of the same variables that Xia did, right? They have this age variable, and then they also only had baseline variables because their paper was specifically interested in treatment difference. It doesn't make sense to include FEV over time if you have a treatment and a placebo group. But we don't have age, we don't have FEV1 specifically the variable. We have an FEV type variable in our model.
So probably just, you said this, but just to emphasize. The previous model was based on deciding whether azithromycin was effective adjusted for baseline covariates. And all the other models that are being looked at are only about predicting, no matter where you are in the clinical trial, what's your probability of being exacerbation free for that next period of time, and what covariates can be used to predict that, which means you really can't do much to talk about treatment effect anymore because you've really started to include things that could be changed by treatment over time as predictors. So if your goal is prediction, you can do this and include longitudinal things that were affected by treatment, but if your main goal is to discover if the treatment's effective, you can't adjust for anything past baseline. So really the science behind some of these models is different, and one's just for reference because that's all that was out. So this is really, for prediction, this is a sort of traditional model if you let it go wild with what it puts in there to predict.
This is potentially much more useful for a clinician who is seeing a patient saying, these are the things that matter right now.
Yeah,
Not just
if you
visit.
want, yeah. I mean, the idea behind all these prediction models is if you know all their predictors and you can type them into some app, you get a prediction. And the question is this the model that's behind the app? Or is a random forest the model behind the app? One is easier to explain to a clinician why the prediction works a certain way than the other, I think.
So these were all of the variables that our random forest popped out. So these were because we had this partial information and we had to consider the fact that, oh, we might not know what your history is at time T, we kind of did like a little bit of a Rubin's rule combination behind the scenes. We had 10 different multiply imputed data sets to kind of just make sure we were really characterizing the uncertainty in our partial history estimate. And so the predictors that we're including here had a statistically significant permutation test for at least one of our data sets. There were additional predictors that the random forest used, right? Because the random forest is just going to use everything that it can. It's going to keep making splits until you tell it stop making splits. You know, we've minimized our objective function as much as possible. And so additional predictors were included, but we just didn't have space to show them all. And again, we've got this patient history. You know, did you have your exacerbations at a specific time? What was your rate of exacerbation? These are all really correlated variables that we weren't able to include in a GEE model, because then all of a sudden you have model instability. You have huge variance estimates. But again, we see similar types of variables popping out as the ones that we thought about last time. We've got male gender. We've got, you know, how is your mental health doing at time T? We've got some clinical measures. Treatment group is still popping up. What are the medications that you're on? So this one is a little bit more black box. We don't know what the cutoff points are for these. We don't have point estimates for these. We don't necessarily have the same interpretation skills that you would if you had a GEE model. But the trade-off there is that the C statistic for a random forest is much better than the C statistic for the Shia model, which was model 1, and the model that we just kind of started including based on Wald statistics for model 2. One of the interesting things is that the treatment effect model validated really well in our data. So even if you weren't looking specifically at prediction or allowing these time varying covariates into your treatment model, you're still getting pretty good prediction relative to something that is specifically allowing these covariates to change over time. Random forest was outperforming both of these models. So it's this, again, this trade-off that we talked about earlier, where if you bring this to a clinician and say, oh, look at my model, here are these point estimates and variances that we can interpret together, versus here's an app, we're gonna plug in some stuff and you're just gonna get a very black box estimate out.
You were mentioning that the estimators change over time. What model was that? Is that the one with the sign function? Or when you say they change over time, they have to have this?
So this was in a trial of the effectiveness of azithromycin in COPD patients. And so because you're trying out a new drug, you have patients coming back in over time. And so maybe we're going to measure your mental health at month 0, and then we're going to measure your mental health again at month 90.
So is
Sorry.
this like all baseline or,
This is in baseline.
so I mean,
I'm just wondering if the estimators themselves are functions of time.
they are,
They are, I see. So
depends on when.
and that's part of how this happened. Because I don't see that in here. I don't see any function of time in the estimates. That's just, I didn't know where that is. You know,
So.
I just see
the
that,
time T for your window start times is being hidden from the intuition a little bit.
Okay. Okay.
So each of those little T's in the covariates are, what was your pains? I just pulled out the first one I saw. What was your pain score for the follow-up window starting at time like 60 days? So they would have measures of pain over time that were collected.
those changed, and then based on those, you could predict.
Right.
I see, okay. So and I was thinking that's sort of like the variable changes, but not the estimator changes, because the coefficient is the same.
Yeah, so if you're trying to predict what's gonna happen at time 180, it might be that you have a few different covariates related
That are there.
to the past from recorded in previous windows that could contribute, so. And all of those might have splits based on what happened at time 0. I don't know why I focused on pain, I'm a dark person. But you could have a split based on baseline pain, and then if pain's really important, maybe the split of what happened 30 days later. So all of this, you know, kind of gets updated as you go through.
Interesting, thanks.
But it's time varying covariates, it's not time varying model, it's not a beta changing,
It's not a,
and I know there are betas here.
it's not a beta chaining, it's for the XMT model, it's the covariates themselves that are
Yes.
being put into the model to predict over time what happens.
Yes.
Yeah. I think they call this dynamic prediction when they want to sound fancy in papers these days. It just means that you take whatever data you have in your hand at that moment and it's dynamically changing the prediction.
So this is one other nice visualization we can think about. So each of our models has, we can think about putting all of our covariates and then considering their relative type Z-scores. Each of our models in a different colors. The random forest is in purple this time. Model 1, we should really change the coloring on this graphic. Model 1, the Shia treatment model is teal, and then model 2 is the Wald Z-score selection model. And that one is in yellow. And so we can think about the ways that they have similar selection mechanisms. So exacerbation in 0 to 30 days prior to time t was important in both of the random forest and the Wald forward selection model. The number of variables that are popping up for a random forest as being important is a lot more than the ones for model 2 or model 1. But they all have, when they are showing up together, they are showing up in relatively same magnitude numbers. Yeah, and it's just another nice way of thinking about what are the important factors in a patient's outcome. Okay, so to wrap it up, we talked about recurrent events and how we can understand them, convert them into a censored longitudinal data structure, and then think about pseudo-observation as a way of avoiding classical censoring problem. Talked about a random forest and a special random forest algorithm, discussed questions that random forest can and cannot answer, and then thought about the ways that we can include patient information in these kinds of analyses. Looked at a simulation study and thought about predicting in an actual data example for chronic obstructive pulmonary disorder patients. You have questions? Hopefully we will have a paper on the archive. Well, we do have a paper on the archive. Hopefully it will get published. And then these are the sources, and I'd like to thank Susan and Jenka, who is not here, for being my advisors and being very patient with me as I work through this. Yeah, take any questions.
Thank you for going over too. Thank you very much.
Yeah, good stuff.
Great talk. I have to run, I have a show.
Yeah, so there is.
Any questions?
I had one last question about the assumption that from the very beginning, when it says that the censoring time is independent of the TIs, because it would seem like if as TI becomes infinite, the censoring time is going to be related to that, because you're going to be more likely to censor as the time becomes large.
Yeah, I think that was an
Is that misunderstanding? It might be I'm misunderstanding.
Yeah, the assumption is that patients can have like as many events go on and on and on and on, but we're going to impose a censoring that is going to be independent of the patient's event time.
Oh, okay, that's different.
Yeah.
Thank you, yeah.
Is that independent strictly, or is it conditional on observed
It
covariates?
is strict independence.
That's one solution to dependent censoring problems in traditional survival analysis. If you condition on it, then, you know, it solves your problems.
Yeah.
Does this, so gap time is one approach. Is there any way that this goes to other ways that traditional people like me do recurrent event analysis?
What do you mean by that?
So I think there are kind of three different ways that people do it, but rather than focusing on the gap times, you know, there was a start to that experiment. And so you could be measuring all your times from randomization instead of time since last event,
Mhm.
and is
Yeah.
that,
I think the problem then is with censoring, right? Because if you start looking at times from baseline, then if you don't include the fact that we have censoring, we're gonna be leaving some information and some survival time possibly on the table. Right, without considering the fact that we have some censored data, so we aren't gonna observe everything. But like you could have an event at day 90, and then you could be censored at day 110. There's that 20 days where you didn't have an event, and so we won't be able to include that time as well.
Are there, or have you considered any like really Bayesian methods for this?
No, I have not.
Are you,
Um,
no, you won't, or,
I would love to. I think there's some stuff with. I know that there are Bayesian type approaches people have taken with this. I think with the censored longitudinal data framework, we can really just kind of dig our heels in frequentist world. To my knowledge, there's not censored longitudinal data and Bayesian like existing. I think largely because this censored longitudinal data framework came from a frequentist perspective in like 2015. And so there hasn't been a lot of exploration, but definitely there's the possibility for it.
fabulous. Thank you very much for coming, and I hope to see the rest of you at that June 8th symposium workshop. If you need information, let me know.
All right.